Juba in South Sudan. Here in the capital, life moves with resilience and urgency. But behind the rhythm of the city lies a silent emergency. For thousands of women across this young nation, pregnancy is not only a time of hope, it is a moment of profound risk. As political tensions escalate and violence spread across Upper Nile, Greater Pibor, Unity, Central Equatoria, and Warab states, fragile health services collapse under insecurity and neglect. Clinics close, roads become impassable, skilled health workers flee. For pregnant women, these disruptions turn childbirth into an unthinkable gamble, where survival is not guaranteed and sometimes only the mother lives and other times only the baby. This is the story of mothers on the front line of survival and the urgent fight to ensure that in South Sudan, childbirth no longer comes at the cost of lives. Marua, one of the most marginalized areas in the remote Greater Pibor administrative area. There is no government hospital or clinic here. No motorable roads and vast distances separate communities. Each month, about 670 women are pregnant here, most of them semi-nomadic, moving with their herds and struggling to access even basic care. After recent rains, the plains are surprisingly green, a rare splash of life across this arid land surrounded by hills. The area is semi-nomadic. Many families move constantly with their herds following the seasons for water and grazing pasture, while others stay in villages tending small plots of crops. The market is vibrant, people selling meat from game hunted in nearby forests and trading goods under the blazing sun. The only health facility is a Medicine Sans Frontiers facility, serving a population spread across vast distances. Most pregnant women here rely on this single facility, often traveling long hours. But midwives and traditional birth attendants are rewriting the story, going out to reach women where they are, bringing healthcare to the heart of the plains. I joined the midwives accompanied by the MSF Health Promotion Activity Manager on an early morning visit. The roads are impassable, leaving walking as the only option. The only car available is reserved for emergencies, so the team sets out on foot, navigating dusty paths across scattered villages to reach the pregnant women who need them the most. This is what traditional birth attendants and midwives go through every day. Long walks under the scorching sun in search of pregnant women in need of maternal health care services. In a day, they can take care of 10 pregnant women in this particular village in collaboration with healthcare providers from MSF. After a 30-minute walk, we arrive in Noer village where we are greeted by a mother expecting her 7th child. She's 37th third wife in her household and 7 months pregnant. A traditional birth attendant from the team attends to her, checking her condition and confirming that both mother and the baby are doing well.
Before the health facility was established, I faced many challenges during pregnancy and delivery. There was no food, no medicine, and we depended only on the traditional remedies. There were no injections for pregnant women or even for the babies. When I had a miscarriage, I went to the health facility and I was helped and treated with care. That is why I have decided not to go to the keto camp and instead stay near the facility so I can receive proper care.
She has already endured 2 miscarriages due to pregnancy complications and now hopes for a safe delivery. So far, she has attended 3 antenatal care visits, with only 2 remaining.
I had my first miscarriage at 4 months, and the last one happened at 9 months. It was a very painful experience for me.
After delivering her first 5 children at home, she chose to have her last delivery at the hospital, where she experienced a safer and more supported birth.
I know that when my time to deliver comes, I'll be handled properly at the MSF clinic. I am confident that I will receive the right medicines and care.
The work continues, leading us to yet another pregnant woman, Mochi Konyi. She's 18 years old and is experiencing her first pregnancy. Her husband, a pastoralist, has gone to the cattle camp in search of pasture, leaving her at a neighbor's home.
If I were to go to the cattle camp, which is very far, I wouldn't have the experience or support I need, especially since this is the first pregnancy. Staying here gives me a better chance for a safe delivery for both me and my baby.
She's 8 months pregnant. During the checkup, the midwives noticed something unusual with her pregnancy and decide to refer her immediately to the clinic for further checkups. Gabono Chorchor has been a traditional birth attendant for over 30 years, supporting mothers through pregnancy. Over the years, she has witnessed both victories and risks, while also facing the heartbreaking loss of some women who died while giving life.
Before the clinic was established, all deliveries were at great risk. Many women used to pass away due to complications, and we had numerous cases of maternal deaths in the past. In 2019, I experienced the painful loss of a woman while I was assisting her during childbirth. But today, thanks to the clinic and better access to care, maternal deaths have significantly decreased.
She highlights some of the complications that were associated with maternal deaths in the past.
After delivery, some women would experience excessive bleeding or retained placenta, and I was unable to handle such cases on my own. Every pregnancy is different. Sometimes, the first can be straightforward, while the next may be more complicated.
Mother Kujo is another traditional birth attendant and women's leader here. She recalls the dangers vividly. She experienced 10 maternal deaths in 2020 alone, while assisting women in the cattle camps.
The problem is for women who live far from the clinic. They cannot walk long distances and have no access to health care. Just last month, a woman died in a cattle camp because she could not reach the facility in time.
At the clinic, Konyi undergoes several checkups: blood pressure, fetal heart rate, and ultrasound scans. The midwife noticed signs of obstructed labor, strong contractions, but no progress.
Her weight is 48, and then the MWAG is 20. She's likely malnutrition. She's also suffering malnutrition. And then the big baby size for her. And then also the position of the baby also is not a normal one. It is breech. And then she was brought in labor, active phase of labor. There is progress of labor, but the descent is not taking place. That means she is having obstructed labor, that she needs emergency C-section.
Immediate medical intervention is needed to ensure the safety of both mother and baby. She requires a cesarean section, but the clinic is only a primary facility and cannot perform surgery. The nearest hospital is 45 kilometers away in Boma, with no road connecting the two locations.
The mother may suffer severe consequences like ruptured uterus because of regular uterine contractions, and there will be intrauterine fetal deaths. Yeah, and then maternal deaths. If uterus ruptured, definitely the mother will die. If not rushed to hospital on time. Yeah.
The car is fitted with a mattress on the carrier, where the young mother lies uncomfortably. She's accompanied by a midwife and a relative.
We don't have ambulance, and the roads are full of water, especially when it is rain season. Even if I myself have cars, access of this road by car is also a major challenge in this setting.
The journey begins. A quad bike leads the way, struggling to carve a path through the thicket. Behind it, the car carrying the young mother follows slowly. We crawl at 5 to 6 kilometers per hour over mounds of antihills and grasslands. The car brushes against spiky trees. The heat is 40 degrees Celsius, no air conditioning. Back at the hospital, the midwife supervisor, Beatrice, remains in constant communication with the clinic to provide updates on the patient's progress.
Okay, tak masuk ke garage. Yala, ya bebe ngake. Olisa gawa de zede. Kalas pues lakini mafi weleda mafi don mafi ajamushi. Kalas pues. Yala, tabe ngake kama.
Ara kutale na sabu made fifi atumel.
The car cannot cross flooded areas. After a 2-hour drive, we wait for a better vehicle to meet us and carry the mother for the rest of the journey. The tension is heavy. We learned that the car had been stuck for 2 days with another mother being returned to Marua after delivery. Tragically, she lost her baby in the hospital, almost a similar case to these young girls. After an hour of waiting, the mud-caked replacement vehicle finally arrives. The transfer begins swiftly, but the young mother remains in visible pain. She groans softly with every movement measured and cautious. Every second counts. At the hospital, a growing number of women continue to attend antenatal and postnatal care visits. During the rainy season, more families settle in their homes as pasture becomes available for their livestock. Hence, attendance remains high. Each village is supported by 2 traditional birth attendants who play a key role in maternal and newborn care within the community. Although a total of 1,672 pregnant women were registered for ANC consultations between January and October 2025, with 813 initiating care in the first trimester, only 219 deliveries were conducted at the facility during the same period. This means that just 13% of women who initiated antenatal care ultimately delivered at the health facility, leaving a gap of 87% who did not return for facility-based childbirth.
And most cases they arrive here at a very bad stage. Could be like home delivery. We experience here about 5 retained placenta with severe PPH from home, and anemia also because they bleed a lot. So those are the cases that we normally resuscitate here, and then some of them we see refer them back for further management like transfusion. Most of our mothers that attend ANC here we ensure we know them. At least we check with them who is next to you. So in case of anything, we reach out to these women. Those are the tasks we carry upon ourselves as midwives, to follow up these women with nearby their community, their family members. But those ones coming from cattle camp, we are not knowing them. It is just their first time coming to us. It could be something they have been trying from home and there is no results.
Continuity of care was as low as only 109 women completed 4 or more ANC visits, with monthly completion rates consistently below 17%. This data indicates that while many women access ANC services early, most do not remain in follow-up through the recommended number of visits, nor do they deliver at the facility, likely due to mobility related to semi-nomadic lifestyles.
This is why we are also during the dry season, we are also organizing outreach activities so that our services could follow them.
Complications identified during pregnancy between January and October 2025 included 266 cases of anemia and 229 cases of malaria among women attending ANC. Healthcare providers have noted that establishing a mother waiting house at the facility would help expectant mothers remain close to skilled care as they approach delivery.
When we send mother, you go, you come back, you are not coming back again because no place to stay, because no food to eat. Some we get a lot of challenges. This mother is anemic. When she's going there, she's delivered the baby, mother, she died. We meet a lot of women, the babies die inside, like stillbirth baby, because she stay in far place sometimes. She's coming only first time, second time, you cannot come in.
In just 8 months, the facility has recorded over 2,000 home visits conducted by community health promoters. The visits also actively engage men to support their wives during pregnancy.
According to the culture, our people, sometimes a man cannot support a woman during delivery day. It's like a secret where some of men, they don't want to attend the births of their wife, and they will be aside. But when MSF is working here, we, in our department, we have encouraged also some men to come and also support a woman as a way of love, as a way of sharing the pains together, as also women to know that a man is also having responsibility. We are even encourage a man to accompany their wife, like for ANC visit.
This reminds me of a case when we had a patient that needed some days of observation in the clinic, and we had this difficulty with his husband that was requiring us to send her back home as soon as possible because she had to take her responsibilities back, as she was the only one responsible for all the household tasks. And so he was really pushing us to let her return back home. So sometimes this collaboration with men is not always easy.
Despite the availability of a fully equipped facility designed for safe deliveries, women continued to give the facility a wide berth, choosing home deliveries due to deep-rooted traditions. But the incorporation of traditional practices like this stool birth, the trend is changing. Ngaram has arrived at the facility to deliver her third baby. She's in pain and is quickly rushed into the delivery room for urgent care. She's accompanied by a trained midwife and 2 traditional birth attendants who remain by her side to offer support and reassurance. The facility intentionally includes TBAs during deliveries to create a sense of familiarity and comfort for pregnant mothers. Some mothers hesitate to be handled by unfamiliar medical staff due to fear and cultural concerns. After several intense pushes, a bouncing baby boy is born. His first cry fills the delivery room. Ngaram, exhausted but overwhelmed with joy, holds her son close as the room shifts from urgency to celebration. Another safe delivery, another life welcomed into the world.
I have 3 children. I delivered 2 in the hospital and 1 at home. Giving birth at home is very difficult. At the hospital, I received injections, soap, and medicine to care for me and my baby.
Postnatal is reducing because still they believe if a woman gives birth, everything is okay. Like they don't bother so much. It is also another thing we see. We also shift our knowledge to our community that it is very important for this woman to come back to be checked.
A lack of consistent counseling and follow-up further contributes to low adoption of family planning methods.
We are providing family planning at the clinic, but we still see that there's low attendance for this service. There are, of course, cultural and social norms that prevent women from accessing these services. In Morle community, children are perceived as a real resource, especially girls, as they are associated with the exchange of dowry. So family planning could be perceived as something going against these norms.
South Sudan has one of the highest maternal mortality ratios globally, with 1,223 maternal deaths for every 100,000 live births, according to the latest UN report of 2017. For newborns, the burden is equally severe, with 40 deaths per 1,000 live births and a stillbirth rate of 26 per 1,000. The United Nations Cooperation Framework Report for 2020 noted that only 19% of births were attended by skilled health personnel, with a high rate of home deliveries, 87%. Emergency care services remain limited, with only 40% of health facilities functional and service delivery being largely provided by international organizations. The poor health indicators are due to several factors, including the weak and underfunded healthcare system.
I think the most pressing issue facing us is the declining financing in terms of health globally. In the health system, 85% of our health is covered by donor funding. However, with the changes, recent global financing for health, it is impacting our services and reaching to the people. However, we are really working very hard with our partners, our government, in terms of ensuring that health service reach to the people without any delays in our services.
Mochi Konyi arrived at Boma Secondary Health Facility and underwent a cesarean section, which was conducted successfully. She safely delivered a bouncing baby girl, bringing relief and joy to both the healthcare staff and her family.
After that terrible incident, a woman walking back healthy, honestly, I smile every day. And I will not forget this woman from my mind. And if they see me here, they are the one they will go out and tell the family, you people don't fear. The midwives and their supervisors, these people are doing great job.
Woman giving birth, when you conduct the delivery, this mother is happy with you. Even you give the name for the baby, like Margaret, she said the baby is Margaret because you are helping me. I have like 5 children now, Margaret.
The contribution of midwives and traditional birth attendants show that preventable maternal deaths can be reduced through skilled care and community-based support. However, with less than 5 years remaining to achieve the global target of reducing the maternal mortality ratio to fewer than 70 deaths per 100,000 live births, much more needs to be done. Margaret Kimathi, NTV in South Sudan.